possibly the deep penetrative veins are also slightly more prominent, maybe some degree of stasis. But yeah, so predominant focal lesions in the posterior aspects. This is a non-contrast T1 sequence, and again you can appreciate that there is a peripheral T1 hyperintensity with isointensities to mixed densities and intensities in the central regions. So multifocal lesions are the two one in the parietal lobes are the largest. Um, I don't think we have contrast. Is that right, Dr. Vic?
Yeah, we didn't have a contrast.
Okay.
So yeah, so when the child came back and saw the MRI, in older children we have seen those MRIs where we have thought about aspergillus and it's a newborn.
Abscesses is that it is bacterial.
Because CSF is completely normal, one cell. Yeah, but abscess sometimes you might not have anything in the CSF, but it's just a child who was going home, and a day before we did a MRI just to be sure, just for the prognosis. It's so difficult to convince them for more, like getting, because we don't have an MRI in our own hospital, we have to send somewhere, so you have to send again in an ambulance for a contrast MRI. So we thought we'll just do a CSF, which is completely normal. So should we still pursue? We should do a contrast MRI. We should pursue infection. Should we pursue aspergillus? Or you think this could be explained by a resolving hematoma?
Very peculiar location for hematomas, only affecting aspects.
I think it's very unlikely to be a solving hematoma. Yeah. Fungal infection, fungal abscess has to be ruled out.
I think contrast needs to be done.
Yeah.
Because the veins are not. There's no.
Apart from the imaging, what is the other suspicion for fungus here?
So clinically, there is because he has been in the hospital 3 weeks, and he had thrombocytopenia in between. He never had culture positivity. But child who has been here, has had a STOMI course, he could have an, infection could be acquired and it could have localized in the brain.
Yeah, but I think thrombocytopenia in itself, it's better to exclude it, but thrombocytopenia might in itself explain all of what we are seeing, right?
So you feel that the blood, it could all be blood, dissolving blood.
It could all be blood, yes. It could all be blood.
Right.
And I don't know whether giving contrast right now, Nihal, is going to help you in any further ways.
Yeah, because it will enhance anyhow, even if it is blood. Those margins will enhance, whether it's blood or not.
Yeah.
But if it is fungal, internal irregular margins also may enhance. So in the hematoma, it's a pure hematoma that will never happen. So only the margins will remain, the periphery only will remain.
So inside the cavity also there will be enhancement.
Inside the cavity, whatever you are seeing as that diffusion restricted areas,
right.
That the margins of that internal margins also may enhance, sometimes fungal. But if it enhances, it is not a hematoma. Outside anyway is going to enhance.
Right. And the diffusion restriction is seen in the subacute stage of hematoma, right? Is that?
I think up to the subacute stage. So again, the diffusion and the blooming, at least the internal portion here is at least showing restricted diffusion, whereas over here it's only the peripheral aspects which is blooming. So I thought if it's bleeding in subacute stage, it should be demonstrating some degree of susceptibility artifacts.
No, all hematomas, subacute stage, it should show uniform diffusion restriction. Here only the periphery is showing diffusion restriction, that too irregular. So if it is bright on T2, I don't know about T1. So then that is relatively uniformly hyperintense. But that the whole thing is not showing any diffusion restriction. If it were a hematoma in the subacute phase, which can show diffusion restriction.
But this is also ruptured the cortex, right? You've got some extraaxial material around there. It's not just within the brain parenchyma as such. It's not all intraaxial. But either way, I mean, as a child immunocompromised, are we using the imaging to diagnose fungal here, or is there a threshold for what it might be? Because fungal in a neonate is very unusual. They get serratia, they get unusual bacteria. Fungal is unusual unless they have a primary driver or some kind of immune deficiency syndrome going on. Enterobacter. In those pictures, yeah, exactly, Citrobacter, all these things. But even in these pictures, you don't easily see fungus in these lists easily.
No,
And if they
especially
are,
the
they are small
neonatal.
candida.
But
The
in your
neonatal.
case, Nihal, in your case, if you go back to the initial scans, it looks like the cortex may have been ruptured in parts because there might be something extraaxially as well. Will confuse your picture, is what I'm saying. But yeah, worth doing for sure. I think Vijay is right about all that. But I still don't know how enhancement in itself can help you call this fungus confidently and nothing else.
Actually, I was thinking more of the typical ones.
Yeah, those might be more relevant. I mean, your Citrobacter, for example, if you see, for instance, those. But again, is imaging. You might as well aspirate it and get it out, or do a CSF or blood analysis for particularly these organisms shown here.
And in my experience, CSF does show some things, especially with Citrobacters and stuff, because you have no cells. So, so infection, these infections look less like. CSF is completely normal.
And you're not worried about leukemia or some kind of infiltrative disorder here, right?
These platelets are normal now. They have resolved. Yeah. So near that confusion which I had, so you mentioned the diffusion restriction. Obviously, that should also show some degree of blooming, which is not there. That's odd. Is that?
That I thought was searched for something else other than blood over there. She's showing
Yeah, because I agree. That's something which confuses, that you've got a part which is restricted, but there is no blooming in that area.
So is that pus or is that some protein-rich content? Was the question.
Yeah. Tej, what do you have to say on that?
Because the question here is this area over here internally it is showing restricted diffusion also over here, but that does not correspond with the blooming foci.
Yeah.
So if it was acute subacute bleed, it should have been possibly some degree of blooming out there. And also on the T1s, it should have been more, I think, depending on the stage, but yeah.
Nihal, if you zoom out the right occipit, right parietal thing, there is still a double ring sign. Do you agree that? I think there is some infection there.
Yeah, that's what I was, yeah.
Dual rim sign.
No, the diffusion DWI was not corresponding, so I thought other than blood, there is something there. So,
yeah. Can you show, Nihal, can you show the double ring?
No, SW you see on the right side, if you zoom, you can see there is a
I can't zoom it, but
dual rim. Hyperindents on the hypo on the outside and hyper on the inside, and again there is another hyper on the right side. See this? So this, why should it happen in a hematoma?
No. There is sepsis. I mean, let me rephrase what I had said. A lot of the hemorrhage can be explained by the thrombocytopenia, but it's not just these two lesions. They've got other lesions elsewhere. The transmedullary veins are quite congested here, actually, and you can see the extraaxial element of that. So you're going to get frank cerebritis when you give your contrast, etc. But I still don't think this is fungal.
No, we are not saying fungal. I mean, I'm saying it's something more than only hematoma in this question.
Yeah, it's a clinical call, right? I mean, we know that there are two drivers to this process: coagulation problems and sepsis, which is most likely bacterial and unusual bacteria. The problem with those unusual bacteria is by the time you image them again, they have larger holes everywhere in the head. So have a low threshold to do some sequence at least. Problem is, what do you do even if it is? Their outcomes are generally pretty bad.
I think best would be to first take it out, if it's possible. Because we are superficial, right? That should be the idea.
Do you have cortical highlighting on that T1 as well, the last picture? Or am I imagining it?
It's going up to the cortex, but
yeah, no, the last one on the third on along that on the all that. So it looks all more bacterial. That's what I'm saying.
Yeah, that's what I thought. But CSF is completely normal, so I was still.
You did it up, Mary. One cell. Even in a newborn, that's surprising. Normally, they at least have 10 to 20. Nothing.
So I think we, yeah. So maybe I MRA and something going on there. That's what we can conclude on. Whether it's paediatric, bacterial, fungal, fungal or bacterial, that possibly is not easy to say on this scan.
Right.
ID scan, I guess.
Okay.
All right.
Vivek, if there some of them are superficial enough, can't we do ultrasound guided tapping from any of the this one? Is it possible?
Okay.
Vivek?
Yeah, we can. We have a neurosurgeon also. So,
I think that might have a specific answer.
yeah.
Either bedside or this one. Because, yeah. Thank you.
Right. So this is a two brothers, both sort of similar phenotype. A 12-year-old boy who has left spastic hemiplegia, intellectual disability, and came to me because of his left focal seizures. And hemiplegia has been since infancy. And he's a younger brother who is similarly affected. 8-year-old boy who is hemiplegic, intellectual disability, and occasional focal seizures. Do you have the video? This is the older boy. Left side beaker. And he is disabled, but not that much. So, but he is like he doesn't perform to the level. Slightly coarse facial features, long nose, thin upper lip, and that's his brother, who sort of looks similar, and again has hemiplegic. So that one is 12 and he's 8, and they look so similar. So I do have the MRI of one of them.
Question: is it progressive hemiplegia from Sridhar?
No, not progressive. Like sort of have been, they both have been same for years.
All right.
Only seizures have started.
For the elder one. Yes.
For the older one.
And the MRI is of the elder one?
Yeah, MRI of the older one.
So yeah, right-sided porencephaly cyst with cortical thinning, volume loss in the right frontal lobe, communicating with the lateral ventricle, which is dilated. There is some reduction in the white matter volume in the periventricular regions, deep white matter on the right side. The gradient sequences not really size thickness, but do not appreciate any mosaicism or calcification of blooming foci around the cavity or within the cavity. Corpus callosum is diffusely thinned. These are the only images which we had. So, porencephaly dilatation of the just with communication with the right ventricle and reduced volume of the right hemispheric white matter. So, given the similar phenotype in both the children, possibility of collagen 4A12 mutations was to be considered. Especially one of the common phenotypes is porencephaly, which is seen in our case. So yeah, this was the only diagnostic consideration. Other than that, perinatal ischemic abnormalities, but maybe unusual for both the children to have the same phenotypes in an acquired cause. So, yeah, thinking of call 4A12, and that was the question of today, am I right?
Yeah. It's just which was interesting, so I thought.
Right. Okay, I'll open the case for any further comments.
No, I don't think there's another differential right here with the two family members affected.
The clinical challenge here would be that if the first child comes, you tell that it's a non-recurrent pathology, you can go for another. This one, is there any handle in this scan to say this could be something genetic rather than you should investigate further?
because if this was first child and you will just say antenatal, perinatal stroke, and you'll say it won't occur again.
Perinatals are very,
Antenatal, not
antenatal. I'm not sure.
antenatal.
As porencephalic dilatation, I mean cystic communication, they usually have diastasis and some other have that
Yeah,
level.
antenatal.
But if this is an antenatal stroke, what territory is it following? That is, if we are calling this as an arterial ischemic stroke. If it's just an infarct, that's fine.
It's both AC and MCA.
That would be again.
That would be unusual.
Yeah.
Were they twins, the siblings you showed, or
No, 4 years difference.
4 years difference. It will be useful to scan the other one as well, right?
Yeah.
Right. So, genetics to be done, Dr. Ek, or?
Yeah, family has issues, financial, so I will try to get it done.
All right. Thank you. Okay, we'll move over to Pune. Krishna Priya, if you're there.
Yes, sir. Good evening. This is a 7-year-old child, previously well developmentally normal. There was history of a bad RTA in which he lost his father, and following which he was admitted for 2 weeks. A CT done outside. He was admitted outside. The CT was showing a strip of STH along the posterior fossa. Left nasal bone fracture was there, and extracavernal soft tissue swelling in frontal region. About a month later, he developed seizures and raised ICT features and was admitted. And 3-4 days later, he developed dizziness and vomiting, and there was a suspicion of food drop. But his sensorium rapidly deteriorated, and he got intubated. And he had central DI, but the raised ICT measures were continued, and he later recovered. We did an MRI a little late, actually, not initially during the admission because he was not hemodynamically stable. And the MRI with MRI is for the discussion.
The CT, was it done? I have a CT.
CT was done outside. The initial admission was outside. We don't have, only these many images I have, sir. We don't have the other.
So CT of December 16th, is that right? Because I saw 14 November.
Yeah, the first CT is not there.
So 16 December.
First, yeah, the November one is not there. This is the second CT.
Okay, we can see extraaxial hemorrhage out there in the midline in the frontal region, extending into the ventricles, some subarachnoid hemorrhage too, and the cortex is demonstrating edematous, vasogenic edematous changes actually. So the hemorrhage extends up to the falx cerebri. Better appreciated the SAG images out here. So these are the only images we have. No intracranial midline shift herniations or midline shift at this point. Then I think MRI was done 2 days later. Again, you can appreciate subarachnoid hemorrhage, possibly subfield hemorrhage or extraaxial hemorrhage, as you call it. Particle edema, subparticle edema, T2 sequences, flare sequences out there. And the hemorrhage corresponds to the grooving changes on the interface sequences. Some foci of intraventricular hemorrhage in oxygen horns and some degree of subarachnoid hemorrhage in ciliary fissures on both sides. Diffusion sequences on slightly higher up, we have these data restricted diffusion in the left frontal lobe. Corresponding edematous changes on the flare sequences with lower changes on the ADC sequences. The question, then we angio was done. Angio do not appreciate any thrombosis or stenosis. Possibly the hemorrhage is causing some mass effect on the anterior cerebral artery over there, but the flow is going up to the periphery and distal branches. The neck vessels do not demonstrate any abnormalities. So Krishna Priya, the question was cause of the bleed.
Yes, Yeah, and the child still has a partial foot drop. So we were wondering if that is due to the compression still which is there, or is there a infarct because of the compression? Any evidence for that in this?
Okay, so I found few papers with subdural hematoma causing pressure effect resulting in infarcts. But if you think of the imaging as the abnormality of the second MRI as subfield hemorrhage, which are commonly known to have these cortical infarct or ischemic changes because of the compression on the bridging veins. That could possibly be an explanation, but I haven't seen subfield hemorrhage in this age group, more in the neonatal age group. No aneurysm per se on the angio, so this is the only explanation I could think of. Pressure effect by the bleed causing a pressure, I mean, effect on the cortical veins, resulting in infarct that changes.
Is there injury to the pituitary stalk, which explains the central DI here, because the location of the hemorrhage is quite close to all that?
MRI don't have a SAG, but here it's possibly going up to the suprasellar region.
I mean, Sridhar is right, but I think we should be looking out for on MRI, particularly any obvious disruption of the stalk. The ischemia of the brain associated with the subdural is fine because it causes a micro circulation problem locally with its pressure effects and all that. So you can get ischemia. That's not a surprise, whether it is subpial or whatever it might be. But quite a sad story. I mean, are we labeling this as diffuse axonal injury then?
The sensorium of the child has gradually improved over the last 1 month, sir. Now he is responding to questions. He has started walking with support. If it is a diffuse injury, will he improve so much?
Probably not. I mean, at least on the images here, we're not seeing very eloquent areas which typically go with DAI, but looks like the hit was significant. The recovery is there, but low, isn't it? Children will undergo a lot.
Yes. Yeah, it has been 1.5 months. Yeah. Recently, last week only, he started walking a little bit.
And there are some punctate foci over here in the parenchyma basic control region, but I think predominantly it's extraaxial, the hemorrhage. So
Yeah, for that we did his coagulation profile also, thinking if there is any derangement, is that why? Those were all normals.
And has the central DI improved in 1.5 months?
No, sir, he still has hyponatremia and he's on desmopressin.
So I think he's transected his pituitary stalk from trauma. If you see that sagittal CT, it is so close to all that, there would be a direct impact.
Should we do any further imaging to look at that?
I mean, if you can provide us the MRI SAG of this is something.
Okay, I'll try to send it.
I mean, was it not commented, I guess?
It was no, there was no comment on the pituitary stalk. I just looked at the bright spot whether it is there because of the DI, but I thought that it is there.
If you see, at least now it is. If you see the outline of the hematoma is in the region of the suprasellar sellar.
Yeah.
Nihal, radiologists don't always review that area, and we don't always mention what happens to the stalk and all that. So it'll be a question of going back and looking at it. But yeah. I don't think everything can be explained by an SIADH related to the trauma per se at 1.5 months, right?
Dynamic pituitary function test. Is that a MRI or is Dr. Rajiv? I think dynamic pituitary function test. I'm not sure if that. Is that a clinical test? Any idea?
No, sir. I will have to look it up. Not sure.
I think for starters, maybe look at the entire scan in totality.
Yeah, sure.
But the ischemia and hemorrhage is pretty evident. It is causing pressure effect and resulting in ischemia to extract hemorrhage. So we'll have to look at the pituitary and stuff. Maybe you can send in the images or the entire scan.
Yeah, I'll.
Over to you. Krishnapriya, over to you.
It's a second child. Here, she's a 7-year-old female with no significant perinatal or family history. She has 3 healthy siblings, which are all girls. She had a normal birth weight of 3 kg, and from the 6 month of age, she was a failure to thrive child. From 6 months to 2 years, she had milestones. She was achieving the milestones, but rather slowly, and she could walk with support by the age of 2 years with 3 to 4 words vocabulary. And from 2 years of age, there is motor and cognitive regression. Uh,
We'll play one video at a time. Krishnapriya,
so
maybe.
now she has lost ambulation, and gradually she has lost sitting, and presently she is confined to the bed. There is regression of fine motor as well. Social is preserved. Language, she has lost the words, but bisyllables are there. On examination, there is no transfer of objects. Unidextrous grasp is there. And she has intellectual disability, microcephaly, moderate microcephaly is there. And she has these abnormal eye movements in the video. And she's dysmorphic with a triangular face. She has oromotor dyskinesia and severe wasting, as you can see. And the fundus is normal. Her deep tendon reflexes are much exaggerated with a sustained clonus. There is no history of birth trauma.
User has mentioned paroxysmal tonic upcase. Okay, dopamine transmitter deficiency, AADC deficiency. All right. Let's look at the images. Okay, I have diffusion and ADC sequences over here. You know, appreciate that there is confluent white matter abnormalities in the periventricular deep white matter. Possible cystic foci out here are adjacent to the right frontal horn. The lateral ventricles are slightly prominent, especially on the frontal aspect. There is some reduction in the white matter volume, especially in the posterior aspect. Some diffusion changes in the brainstem structures, but majority of them demonstrate associated diffusion, especially the white matter abnormalities. Brainstem, I wasn't sure if it's true restricted diffusion, but you can see here some degree of edematous changes in the brainstem and the thalamic regions out there. The flare sequences better demonstrate the abnormalities, confluent abnormalities, predominantly in the deep white matter, particle white matter, the frontoparietal regions extending also in the temporal lobes, basal ganglia abnormalities with atrophic changes and signal changes, cystic changes in the adjacent to the right frontal horn, reduced periventricular white matter volume, brainstem edematous changes, again, more on the dorsal aspect. I could not appreciate any structural abnormalities in terms of malformations, particle dysplasias. Sad images of the cysts, multiple cysts, predominantly along the periventricular regions. They do not follow the CSF intensity. They're slightly, you can see that the CSF of the ventricle is dark and slightly more hyperintense. But multiple cystic foci in the periventricular regions, especially on the right side. On contrast, the CT scan, and you can see that there is, again, cystic lesions, no calcifications. I'm not sure if it projects out clearly, but you can see the periventricular abnormality is slightly more hyperdense. Some rim-like hyperdensity along the periventricular regions on the non-contrast CT. Spectroscopy was done in the basal ganglia, and the white matter changes did not demonstrate any significant abnormalities. No lactate, significant lactate peak. Yeah. And then I think question was, Krishnapriya, was it hypomyelinating leukodystrophy, Cocaine syndrome, Peliza's Mosbacher disease, mitochondrial SERPON mutation? I can possibly say that it is none of these, especially if you take imaging in consideration. So predominantly a dysmyelinating or demyelinating leukodystrophy with cystic changes, dorsal striatal atrophic changes, and brainstem hyperintense changes. Not seen in hypomyelinating leukodystrophies, no calcification for cocaine syndrome, not typical for Peliza's Mosbacher, and mitochondrial SERPON also, I don't think it fits into SERPON mutation. Any further questions, Krishnapriya, regarding the case?
Yeah, hi. Sorry to join late. My mobile got discharged. Good evening. Actually, this child had like we are suspecting now a cystic leukoencephalopathy, and there was a severe failure to thrive, and major disability is dystonia. She has very severe oromotor dystonia as well as in fact, she is almost like a log. Very severe dystonia is there. So, how do we fit this together, like cystic leukoencephalopathy with the basal ganglia? That's why we thought of maybe mitochondria.
As far
So,
as
what are the sorry.
sorry, as far as I reckon, it doesn't fit into mitochondrial cysts. So they are really don't have more cavitatory changes rather than cystic changes. And there was no, I mean, spectroscopy is not definite, but there should have been some degree of lactate on the MRS.
Go back to the pictures, Neha.
So this is the main slide which demonstrates all the findings.
So these dark spaces, they are not cavities?
No, they are cysts. The ones over here.
Yeah, so cystic, that's what we thought, cystic leukoencephalopathy.
Yeah.
And the basal ganglia affection, what exactly it is, and is it pointing to any particular disorder?
Basal ganglia, at the moment you are picking up mature scarring, and I think the central tegmental tracts were also involved. So I wouldn't take mitochondrial away from this, Neha. If that is the crux of the question.
Michael, can you show the spectroscopy once more?
There is a choline. What was the age? I forgot the age. Krishna, any idea? 7 years, sorry.
7, 8 years, yeah.
7.
So the choline is elevated for a 7-year-old. Is that right, Dr. Vijay?
Why is it so hyper dense on the CT in these areas?
Looking at that, I thought then, is there a possibility of Alexander's or GFAP-related disorder?
Alexander's did cross my head, with the ventricular garlands and all, but
then I saw the juvenile cases have the cystic abnormalities in them.
She has a moderate microcephaly.
Microcephaly, so
yeah. But that CT was.
It is quite. I mean, we have not seen many mitochondrial CTs, so we don't know what is standard there, right? But these are quite hyperdense, these changes. Unless you guys have seen more CT with mitochondrial disorders.
They usually are hypodense. I mean, anything.
Yeah. And also that thing along the frontal, what we have called cysts or whatever, the density of that is quite unusual.
Yeah, it doesn't point. I mean, at least what cysts we have seen are usually more CSF following in mitos. So I thought maybe labrum, but there was no calcification.
Was there an infection to start with?
No.
Exactly. I think somebody has put cysts look like trapped ventricles. In a way, they do. That's what we get with infections. And so we thought about that.
Any sagittal corpuscular cell pictures are there?
No, these are the only ones. Yeah, I was trying to look for the middle blade, but I was provided only with these images.
But I think still complex 1 and 3 should be ruled out. Complex 2 is out because spectroscopy there is no such net. And SURF1 is unlikely. So I think in addition to whatever we have discussed, mitochondria cannot be entirely ruled out because by right basal ganglia also there are tiny cysts.
I agree with that.
And that
the brainstem changes also would go with that.
Yeah, and the dorsal lemniscal tract that Dr. Manga told.
Because whatever basic metabolic profile we could do was not very conclusive. Of course, in many mitochondria may not get high lactate and all those things. So we have actually sent the whole exome and mitochondrial genome. Let's see. what we get. And the reason for doing the CT was to look for calcification, because initially we thought that it's LCC because it was labeled as hypomyelinating initially.
That's right. I mean, you still
Yeah.
admitting for classification. But the only thing that CT periventricular rim was slightly different.
Sure. Thank you.
Aarti, further?
This is the case of a 6-year-old male child who was the third born of non-consanguineous marriage with a background history of neonatal seizures and speech delay. He was admitted with status epilepticus outside and referred on day 7 of illness. Prior to referring here, he had seizures basically followed by fever on day 4 of illness, and they were left focal seizures and he was ventilated. He was on 4 anti-seizure medications and antibiotics were started, and the seizures were extubated, but seizures continued, so he required a reventilation. Outside, they had done a plain MRI, which has been put up in this presentation, and that shows the retrocerebellar cyst. And the seizures continued, so he was referred. And on arrival to the ER, he had left hemifacial twitching with tonic extensor posturing, and he had papilledema, and bilateral pupils were dilated and reacting. He had a poor GCS, and then his the ventilation was continued, and he was started on midazolam infusion, and he was continued on the same anti-seizure medications as before. When sodium valproate was given, he had transaminitis, so it was stopped. So we continued to, in the first 24 hours, we treated it as acute encephalitic syndrome of infective etiology. Along with the anti-seizure medications, we gave meropenem, vanco, and acyclovir, and MRA was also planned. But he was hemodynamically unstable. He had hypotension, was on inotrope, so he was still just undergoing treatment. EEG initially showed a bilateral frontocentral dysfunction with burst suppression, and also later on also showed a severe bihemispheric dysfunction. Next slide. His encephalopathy was persisting, and his MRI was repeated, and that is again put up here. Considered as demyelination and started on pulse steroids. Seizures were controlled, but encephalopathy persisted, and a trial of, on revisiting the MRI findings, we gave a trial of thiamine at a high dose, 1,500 mg per day, and biotin, following which his encephalopathy had drastically improved. But he still has a waxing and waning of his GCS, and the seizures are controlled, but he has significant dystonia, spasticity, more on the left side, but hemiparesis on the right side. And currently he is on anti-seizure medications, cardinal, levetiracetam, and pyridoxine was started outside. And he has been started on biotin, thiamine, CoQ, and carnitine, riboflavin as well. And his CSF, I think it's coming in the next slide, is normal. And the relevant past history is he had neonatal seizures and he used to have seizures every like 3 months in infancy. The last seizure was around 6 months back. And there is a family history. This is the third born child. The first born baby was a girl who had seizures 15 days of life and expired. MRI for discussion. Investigations. The blood investigations, CBC, CRP were normal. The sodium initially was 150. Lactate, ammonia, and pyruvate were normal. And CSF total count 8 WBCs, 3% neutrophils, 5 remaining lymphocytes. 576 RBCs, and CSF viral and bacterial panel were negative. Sugar protein were in the normal range, and serum MOG is actually awaited. Blood culture showed Acinetobacter baumannii, and toxo IgM serum negative.
Okay. All right. So the initial MRI, there's some degree of ventriculomegaly out here. The posterior fossa extraxal space, especially on the left, convexity is prominent. That was labeled as retrocerebellar. No signal abnormalities in the basal ganglia, thalami, cortical, subcortical regions, possibly some benign cystic foci perivascular spaces in the periventricular regions, and deep white matter. But again, flare, no parenchymal signal changes, maybe some degree of periventricular volume reduction with the ventriculomegaly, and the posterior fossa changes predominantly in the extraxal regions. That was the first MRI. On top of on the flare sequences, I'm not sure if there is some edematous changes, but it appears slightly bright, especially on the left hemisphere. The top panel on the right side. And then diffusion and ADC sequences, we have areas of restricted diffusion in the cortical regions and the bilateral hemispheres. The bilateral basal ganglia demonstrates these confluent patchy abnormalities. The thalamus also has restricted diffusion. The midbrain, especially the ventral aspect, the cerebral peduncles, also demonstrate restricted diffusion. So deep brain nuclear abnormalities with cortical subcortical areas involving the bilateral hemispheres and also brainstem involvement. With cerebellum also has some degree of edematous changes in the bilateral hemispheres. On phase sequences, again, changes of edematous in the subcortical cortical regions, the bilateral basal ganglia, the cerebellum, corresponding changes again on the T2 sequences. So predominant changes in the deep brain nuclei, subcortical cortical regions, the brainstem, and the cerebellum, some degree of thinning of the corpus callosum. These are the main changes on the follow-up scan. The differentials considered were infectious etiology, but given that the child has a long-standing course with neural presentation, possibly unlikely. Biotin thiamine, given that the child has responded, especially in terms of encephalopathy. Cerebellar involvement was slightly atypical, especially in the older age group. In the neonatal early infantile, biotin thiamine can present with cerebellar involvement. But again, the other phenotypes such as the basal ganglia involvement, thalamic involvement, subcortical cortical involvement can be seen in biotin thiamine disorders. And other abnormalities, especially focusing on the basal ganglia dorsal striatum, mitochondrial disorders, organic aciduria to be kept in mind. The question was, is this biotin thiamine responsive basal ganglia disease, Paul G mutation, MELAS, or HIV leukoencephalopathy? That I open the case for a discussion.
There was some iteration with valproate, I think. And Paul-G is Paul-G is a good suspicion, especially with the cortical involvement and bilateral thalamic involvement. Alpha Saturnoper is a possibility.
Yes, sir. We have also considered Paul G. We have actually sent genetics now. The child is still in the ICU. And lactate, ammonia, and pyruvate were normal. We have not done the MR spectroscope. We had a clinical suspicion of encephalitis bar ADAM and then the MRI.
And hypotensive, right? Not hypertensive. Just to rule out unlikely breast.
There was no significant hypertension.
Epilepsy, partialis type, or what was that? Sorry, I forgot.
It was at arrival of the ER, he was having left focal twitching, left focal seizures, but that had got controlled with 2 medications. And following that, he had only activity on the electrographic seizure. And his clinical seizures had got controlled. He had some myoclonic jerking of the left shoulder and but like epilepsia partialis was not very distal and very focal seizures.
We are thinking of differentials as what you have put out: mitochondrial, biotin thiamine transport deficiencies. So genetic is what we are thinking.
Yeah, we have 10 genetics.
There's a question of refractory seizures with hypercytokainemia, related epilepsy, also called fires. Our favorite term in our discussions from Sridhar, can have cytotoxic edema. Would that explain the long-term history of from the neonatal presentation now?
And Nihal, biotin thiamine responsive basal ganglia disease, the cerebellar white matter should involve, like a bat-wing appearance. Here, the cerebellar cortex is involved. So
yeah, that was atypical for biotin.
So, my strong possibility is still a Paul-G disorder.
So, Arti, you can get back to us with the genetics once you have it.
Yes, sure. I'll get back once the results are okay.
Okay. So, in the chat also, people are favoring Paul-G, CNS, HLH, if fever is still persisting. From Sridhar, all right. Okay, we'll get back to you with an answer, but yeah, primary suspicion is of a mitochondrial disorder.
Okay. Thank you. Thank you, Anand.
Okay, Anas, over to you.
So this is about a 4.5-year-old female child. She's a well child prior to March 2024. So problem started from March 2023. Started with fevers. So she had fever triggered seizure in the form of right focal tonic seizure, brief duration. She recovered from that, and from April to November, she had multiple. So she kept on having sporadic seizures despite having no fever, which was well controlled with medications. But in the past 20 days, the seizure frequency and duration kept increasing and involved right hand and face and eyelid on the same side. She was aware during these episodes. There's no behavioral changes, no sleep or other concerns. She was admitted initially at a different center and then eventually at our center. So the seizures were difficult to control despite having 4 to 5 anti-epileptics, and she also received immunomodulation with IV methylprednisolone IVIG and did not show any improvement. So
refractory seizures.
Yeah, it was a EPC with intact awareness.
Another EPC. Okay, all right.
But only on the right side. All the seizures were on the right side.
So this child had a previous scan in November. This is a scan done, I think, a couple of weeks back. I have diffusion sequence on top. Cannot appreciate any signal changes on the diffusion of sequences. Coming down on the flare, there is overall reduction in the brain volume. But if you see the perironic region, especially the precentral gyrus over here, has this clear hyperintensity in the particle regions with some extension in the subcortical area. You see going down medially and inferiorly, there is this hyperintensity along the subcortical particle regions. Does not correspond with any significant diffusion abnormalities. And rest of I cannot appreciate any abnormalities in the rest of the cortical regions. Some hyperintensity of the white matter, but again, not very significant. The corresponding SAT sequence out there. Again, you have these abnormality in the precentral gyrus and overall reduction in the brain volume, especially involving the corpus callosum, the cerebellum, and the cerebral hemispheres on both sides. Then the child had a follow-up only flare sequence, I think, a couple of days later. Is that right, Anas?
Yeah, that's correct.
Yeah, Dr. Yeah. So then you see that the intensity is slightly reduced in comparison to the initial MRI. It's still persistent, but you can see that the cortex outline is more better appreciated. I would argue that the flare sequence wasn't done, size flare wasn't done at that period of time, but you can see that there is some reduction in the hyperintensity. But again, on the SAT sequence, you can appreciate that the focal abnormality is centered in the perironic region out here. Then a PET CT was done, and you can appreciate the multiple areas of hyperperfusion changes in the frontal lobes out there, the basal ganglia, the deviant nuclei, thalami, the perisylvian regions, also in the brainstem and cerebellum. There was also a previous scan in November. I have seen the images, but I just haven't put it up here. But those edematous changes in the left perironic region was not present in the scan done, I think, a couple of weeks prior to the one which you have seen. So multifocal abnormalities on the PET CT, and only this focal area of abnormality is, especially at least what I could see was on the second MRI. Based on that, I think the question was, sorry, Anas, if you want to just round off the investigations.
Initially, dysplasia, which could be amenable to surgical output, but before going for that, we wanted to make sure we're not missing out any pathology or any autoimmune. So we have serum NMDA was done, it was negative. CSF lactate was done, that is normal. Serum lactate was normal. Autoimmune panel has been sent, and whole exome of mitochondrial has been sent as well. So EEG picked artifacts over FP2 and F4 with no physiological waveform during the ictal record. Interictal record could not be gotten because the child was either still has complete seizures only, and then so we could not get a interictal record. Whatever brief it was there, it was just no sleep markers were there during the interictal record.
Yeah, it was a generalized encephalopathic, whatsoever short background we could visualize. Yeah, but we couldn't pick up any, despite of that lesion being very superficial in the superficial cortex, we could not actually pick up any epileptic discharges.
Yeah, then I think we discussed after seeing the PET scan, we got a possibility of Pathology, given that there were multiple areas of PET uptake, the periodic sign is supposedly not to be seen in Pathology, but at least what we are seeing is diffusion is usually positive, but that possibly can be related to the stage of the scan. So our child also had a periodic abnormalities in the left side, slightly hyperintense. On the follow-up scans, you can see that the deep blend nuclei can also be involved, and this is an ASL sequence which has multiple areas of increased uptake for fusion changes. So given the EPC presentation with that sign on the MRI and then the PET study, thinking of possibility of a Pathology-related disorder. Is that right, Dr. Nikhil?
Yes. So
the serum lactate and blood lactate went.
Serum lactate and blood lactate paired samples are normal. Yeah, and we have sent autoimmune panel. It's not a strong suspicion because bilateral PET changes that would be very unusual to begin with in Rasmussen's. Majority of the Rasmussen's will be sort of unilateral. They can be bilateral, but majority of them will be unilateral. So autoimmune versus Pathology. Pathology is a strong possibility here. Versus autoimmune, we are trying to rule out just because it would be more treatable.
Question of spectroscopy, we did not suspect mitochondrial on the initial scan. The PET CT was done after the MRI, so I think mass spectroscopy wasn't done. I'll open the case if anyone wants to add comments. I think Sridhar has mentioned possibility of Pathology and Rasmussen encephalitis.
Yeah, and Dr. Nihal, just when we were reviewing the scan, we also felt that left quadrant is slightly bulkier and has slightly increased signal as compared to the right side.
Okay.
I mean, if you especially look at the top, the body of quadrant especially.
That's a diffusion on top.
No. As in the sections which involve, you may not have put it here. It doesn't.
Yeah,
yeah. The MR was much more in favor of Rasmussen's looking at MR, but then PET deviates that diagnosis to, yeah.
Mogad, Yogesh, I don't think.
History is like quite prolonged, 8 months. Yeah. So I wouldn't consider Mogad probably.
All right, so I think Pathology is what we are considering.
Sure.
Dr. Vijay, any comments or any suggestions? Anything to add, imaging-wise, to be done?
I think these are good suggestions, and Pathology is again high on the list.
Okay, the other question is, will we see this sort of unilateral white matter abnormalities if it is Pathology spectrum?
Yes, it can come. It is not that it will be always showing only this. It can produce cortical, subcortical white matter involvement, predominantly occipital and parietal region, usually unilateral to start with. But it's all possible with alpha Saturn blocker.
Here the white matter changes are primarily anterior rather than posterior, looks like.
Yeah, it's all. It is not that it will only show that perolandic or only posterior involvement. It's not like
it's a spectrum.
We have seen cases with anterior involvement as well.
Sure. Okay.
And what we have not seen on the MRI clearly, maybe the PET demonstrates over here. So
yeah.
All right. Hopefully, we'll come back with the result on that case.
Yeah. Sure.
Thank you. Okay, Anas, what do you?
9-year-old right? He's born to consanguineous parents, 6th in birth order. He had baseline mild development delay. He attained supported walking by 1.5 years of age, and he speak few words. That is baseline, and then later, before the premorbidly, he could go up and down the stairs independently. So he had seizures from 4 years of age, right focal, which were well controlled. So what happened 2 months earlier? So they are from Somalia, not from here. So 2 months back, child had left focal seizures. Post the seizure, he had weakness, which is gradually improving over the past 2 months, but it's still there. Since then, his speech output has reduced. This behavioral issues, the form of aggression and excessive laughing, smiling behavior. His sleep is disturbed. He is not able to recognize parents. He is dependent on the parents for activities of daily living. So, on examination, his circumference 53 centimeters. He was smiling all the time and appropriately. There was in the left upper and lower limb there was spasticity, pyramidal sign in the form of spasticity and brisk reflexes and extensor planta.
Okay. MRI, I think recently, or what was the timeline?
Yes, sir. The MRI was done recently.
It's an external scan, if I'm not mistaken.
Yes.
So MRI, we can appreciate again global reduction in volume, predominantly in the cortical regions, supratentorial and infratentorially. There were some subcortical particle hyperintense changes. See over here in the right frontal lobe, the temporal lobe out here, especially on the D2A sequences, better appreciate on the flare sequences on bottom. The subcortical particle hyperintense changes between the frontal lobe, the bilateral temporal lobe out here, see in the last image over here, right temporal lobe slightly more than the left, but bilateral temporal lobe abnormalities, the basal ganglia, possibly the putamen slightly reduced in volume. Periventricular, some hyperintensities, but not significant, some degree of mild lateral ventricularity, given that there's overall reduction in the volume of the brain parenchyma. I could not appreciate any structural abnormalities, malformations, related changes. On the diffusion weighted sequences, there was some degree of eye signal changes in the frontal cortex, the anterior basal ganglia. On the DWS sequences, if you see on the temporal lobe, the right side more than the left. But the corresponding ADCs does not fully restrict or show low signal changes. Possibly some degree of T2 shading out here. The frontal regions, see the cortex is slightly low in signal. So some degree of frontal abnormalities out here, the cortex are slightly hypointense. So mixed pattern of edematous changes, especially in the cortex and the anterior basal ganglia, with a background of volume loss in the supra and infratemporal plane. I have a sag image, midline image, again demonstrating the atrophic changes in the corpus callosum, the vermis, and the supratentorial structures. Given that these abnormalities, thinking of imaging-wise, I thought of possibility of autoimmune encephalitis was one of the considerations. The other possibility I thought was SSP. I'm not sure if it clinically corroborates the later stage of SSP. Any chronic viral encephalitis related conditions. And there was a question of mitochondrial disorder as a possibility. Imaging-wise, I could not put it into a phenotype for a mitochondrial disorder. Not ruled out, but I couldn't suggest a possible complex or subtype for a mitochondrial disorder. HLH was another consideration, especially given the blast panel here, atrophy with subcortical particle changes. On imaging-wise, these are the differentials that we thought of. And the investigations, Anasya.
So we have sent autoimmune panel and the measles antibodies. Though he did have history of fever with rash, but it was very non-specific and we could not come to any conclusion. He didn't have any myoclonus or head drops. But yeah, he was fitting. I mean, there was some background history of development delay. That is why clinically we're thinking of mitochondrial. But I think
stroke-like episodes like Mela's type phenotype.
Not earlier. So this is the first time he had this weakness.
Right. So autoimmune and measles to be awaited, but clinically thinking of possibility of mitochondrial.
Yes, sir. And radiologic, I mean, clinically autoimmune as well, in the background of some development delay.
The only question was autoimmune was a little long-standing, if I'm not mistaken.
Yes.
Was the only thing which was against autoimmune.
Yes, sir. Yes.
And no behavioral changes till now.
Behavioral changes are there, sir, like in the form of like the encephalopathy, this smiling behavior. There's definitely a change in his behavior compared to the baseline.
All right, I'll open the case for any further suggestions, comments.
Here the cerebellum is also showing a little atrophy, and the previous cases also had the cerebellar atrophy. Another thing we can fail to mention previously, the two cases of Paul G. The inferior olivary nucleus, we have to specifically see whether any HOD is there or not. Because Paul G disorders can show hypertrophic olivary degeneration like picture.
EEG, Anas, the question of EEG?
EEG had just background slowing. There was no radiomechanical complexes for SSP.
So, Dr. Vijay, mitochondria is still a possibility.
This case, I don't know whether mitochondrial is the first possibility, but obviously it's one of the possibilities. More, I think I will think of a more of an autoimmune encephalitic process in this case. Because the temporal involvement, it is more diffuse. It's not like melas or anything.
Yeah.
That's what I feel.
The cortex, I mean, the thickness is not gliotic type abnormality. Melas, chronic sequelae.
Only worry is that the cerebrum and cerebellum is showing significant volume loss.
Yeah.
So whether that is pointing to something like, especially the cerebellar volume loss. Spectroscopy is not there here also, I suppose.
Oh yeah, this external scan, I think not. No spectroscopy.
We have some genetics and as well as autoimmune panel. I think we'll be getting it in a.
So imaging wise, at least we are thinking autoimmune first.
Okay.
Then maybe mitochondrial, a second possibility. So clinically suspected. You see, there is a I think child has momocephaly.
Yeah, he didn't have a microscope.
Mog, I think again Mog is a question.
We were not thinking in terms of Mog based on the subacute to.
Yeah.
HIV is negative. HIV, HSB, HBsAg, HCV is negative.
All right. I think that's it. No further comments or suggestions. So get back to us with the answer.
Thank you so much. Yeah.
All right. I think that's the last case. Priya isn't there. We'll discuss this case on the next session.
Nihal, any follow-up of the previous cases? Any?
I think one follow-up was that. Aarti, if you're there, if you just can tell us. The one with the multiple enhancing lesions, if you remember, Vijay, we had multiple scans. Fungal was stopped.
Fungal, yeah. What was that?
Today evening, the scan was done. They are stopping antibiotics. Anas, is that right? This is the patient. I don't want to give out the name, but
yeah. It's doing quite well.
Abhishek is there, yeah.
No, we've just changed the just reduced one antibiotic, continuing on ceftriaxone and added oral linezolid. Two more weeks.
They look, I mean, just maybe slightly reduced or so just following the trajectory of the bacterial etiology, I guess.
Likely, very likely bacterial.
Okay.
Yeah, there was one more from Kim's, but they haven't sent the images. Maybe I'll put it up next time.
Okay, thank you.
Thank you. Yeah, we'll meet again in the next year. So thank you, everyone.
Happy New Year.
Wish you all a happy New Year.
Happy New Year. See you.
Thank you. See you.